man of 45 years age with a few risk factors like diabetes and hypertension in the middle of the night develops for the first time in his life unexplained chest pain. Unless proved otherwise, our diagnosis was acute coronary syndrome or an onset of myocardial infarction. Suddenly, has it changed? Has COVID created a beneficial action on the acute coronary syndrome? No. So please remember that the treatment continues to be the same. Treatment, forget about it, but the prognosis, incidence, occurrence, prevalence, they are the same. Only thing is that we don't notice it because people are afraid to come to the hospital. So they come either very late or some of them lose life before going to the hospital itself. All right. Now, one more thing. We are talking about the guidelines. There are no guidelines. Guidelines require randomized controlled trials, and that cannot be done currently only on the ethical grounds. So these are guidances, and these guidances are so many variables and so much different from each other that you will have to assimilate what you think is appropriate. What has complicated the acute coronary syndrome in presentation as well as in diagnosis? Any patient who comes to the hospital, he has not come with the status of coronary or COVID-19 status. We don't know because it has come as a bolt from the blue. What is the problem? Because now we know that COVID-19 has so many cardiac complications too. Acute myocarditis, acute coronary syndrome, arrhythmia and cardiac arrest. They may come like a cardiomyopathy and heart failure or a shock. Yeah, so all these things are complicating the clear diagnosis of acute coronary syndrome. So what should we do? I would suggest to the family physicians, irrespective of COVID status. So what do we do now? What about how do we solve the problem? Well, any patient who has a high suspiciousness or any suspicion index of acute coronary syndrome, without any modification in your thought process, send him to the hospital, the nearest hospital. Now, thinking that he may be having COVID-19 simultaneously because we don't know the status, don't worry. We have to take the precautions, but we cannot dismiss the diagnosis. They are not untouchable anymore. So therefore, we have to treat him the way we were treating before with additional. One thing which was not emphasized, which I want to emphasize now, because we have to diagnose acute coronary syndrome requires the treatment initiation in the matter of few minutes. For example, I want to tell you, door to balloon time. That means the moment the patient reaches the hospital door, till the time that he is taken on the catheterization table for a primary angioplasty, is allowed to be about 60 minutes. I'm very proud to say in Jaslok hospital, the average time has been 23 minutes. So now what is to be done? Well, I think what I would do that, yes, I want to protect myself. I want to prognosticate the patient by additional COVID-19, and I want to alert the staff and so on and so forth. Everything has been talked about in great detail, so I do not want to repeat, but immediately HRCT should be done. And why so? Because the results would come in less than 20 minutes. And predictive value, negative predictive value, meaning thereby, if the HRCT is completely normal, then the possibility of you dealing with a COVID-19 patient is very, very low. I can't say zero, but nothing is zero in medicine. Sensitivity and specificity of any test, if it is 100%, the predictive values are also 100%. If the sensitivity and specificities are 100%, that means if the COVID positive, it is COVID, if COVID negative is not COVID. Such is not the case in any test whatsoever so far in medical science. If I find that the patient has ST elevation, myocardial infarction, then if the patient is stable and it has come within 12 hours of time, our recommendation was thrombolytic therapy. Why thrombolytic therapy? Thrombolytic therapy is actually speaking quite inferior therapy as compared to PAMI, primary angioplasty. But then why do you choose this? Well, in a mild to moderate case who is hemodynamically stable, inferior wall myocardial infarction, such a patient may be offered thrombolysis because if he has come especially early, then the results of thrombolysis and PAMI, the difference is marginal. But there is one more thing, and additionally, a risk stratification. primary angioplasty pre-requirement, prerequisition is to do an angiography. An angiography re-stratifies the patient. How? There may be additional reason. For example, 35 to 45% of the patients will have a multivessel disease. Are we going to treat him the same way like a single vessel disease? No. So this is important. If the patient, so I have changed my own guidance from my experience that now that we know a lot more about COVID-19, therefore I would say that if the patient in your judgment deserves the primary angioplasty, then I think we should take him for without any hesitation, with maximum precaution, which have been already outlined by Dr. Sushil Bindru and the other people. Why am I saying this? The reason is this, that acute coronary syndrome is not a one-point condition. It's a dynamic process. A patient who looks benign, simple, straightforward, within another 2 hours will be extremely serious, and you've wasted a lot of time. Time is the muscle. At every minute, hundreds of myocytes are dying. So I would say that I think develop the courage. And I would differ from what I have said here, because this is taken from the literature, that the thrombolysis is a second choice, especially if the PAMI is contraindicated or primary angioplasty is contraindicated for one reason or other. Such is usually extremely rare. The stable patients generally is being advised to control him clinically, and then later on, especially if he has come after 12 hours. Why 12 hours? Well, because he's gone out of window period. Once the patients are ischemic with a totally occluded coronary artery, the myocytes are dying, and there is an area of infarction, and there will be irreversible. There will be no more life, no more viability, and therefore you should treat them as early as possible and not later than 12 hours for sure. Okay. Then what about the non-ST elevation myocardial infarction? What is the difference? Non-ST elevation myocardial infarction has not got completely irreversible damage, and the artery is not totally occluded in vast majority of the cases. Some flow is going on. Stabilize them medically, and if you can stabilize, allow the infection to get control, and then you can take him up later on. If not so, and if the patient's hemodynamics are unstable, I suppose we'll have to perform the PCI in isolation cath lab. So people who have come with a confirmed corona, what do we do? Well, if he has a confirmed corona, doesn't matter. What is more important is the non-ST elevation myocardial infarction with unstable hemodynamics are likely to pose threat to his life. Then you, without worry, take him to the cath lab, do the angiography, perform the angioplasty, control the infection, put it into a secluded area as per the hospital policy at the COVID indeterminate area. And if the patient is stable, then the medical treatment, and do it selectively or electively coronary angiography at a later date. If the symptoms are refractory, then of course coronary angiography. Elderly people with corona, people who are above the age of 65, they are both at the high risk of corona as well as corona. Incidentally, as well as the coronary disease. So then they should be, if they are not very symptomatic, then they should be managed at home. Otherwise, elective cath lab procedure by giving them the date. Possible corona. Now, this is the subset of patients which I think will be the largest subset of the patient will be possible corona. Forget about possible corona or not possible corona. Your attitude should be that it is unless proved otherwise a possible corona, because prevalence of COVID-19 is so wide and so widespread that you should now treat them as everybody as a possible corona. If there is a ST elevation myocardial infarction, perform the primary PCI, appropriate infectious disease protection for the staff as well as for the patient, and he goes to the designated area. And non-ST elevation myocardial infarction, you can avoid coronary angiography and wait for some time, because till the COVID-19 test comes. Now, we know that it will be the Jaslok hospital is able to offer COVID test in 6 hours time. So that I think it is extremely beneficial in these kind of cases to decide the definitive policy treatment plans. Preferably thrombolytic therapy in a stable patient, and then put them in isolated wards. Then perform PCI in a isolated cath lab. The cath lab has to be previously completely sanitized, everybody wears the PPE protection, and then carefully the patient is shifted at the end of the procedure at a designated area. And so that is for about the STEMI, and the same thing about the non-STEMI also. Response level I will not discuss. Cath lab needs to be carefully weighing the balance between the staff exposure and the patient benefit. Currently, probably now much less, the fear about COVID was so much that the patients were offered inferior treatment so as to distance the patient from procedures. Case decisions are individualized, take into account the risk of COVID-19 exposure vis-a-vis the risk of delay in the diagnosis or therapy. And whenever the PCI is performed and wherever it is indicated, one should not hesitate. The cath lab team must wear personal protective equipments, that is gown, gloves, goggles, shields, and N95, and offer the needed benefit to the deserving patient. Thank you very much.